Now let's discuss assessment of the parathyroid gland function and general calcium status in the body. So in assessing parathyroid and calcium function, the key players or analytes to measure are listed here, including calcium itself, phosphorus and magnesium, and creatinine. Note that both the total and the ionized forms of calcium can be measured, and that serum albumin concentration can affect the measurement of calcium. First, we'll review these key players or analytes. Then we'll look at the measurement of the main regulatory hormones, which are listed here. And finally, while we won't specifically cover the diagnostic approach to parathyroid and calcium disorders here, the main questions or branch points to consider in evaluating these disorders are listed for you to begin considering. So let's first look at calcium itself and how it's distributed in the body. The vast majority of calcium exists in the skeleton, meaning in the bones and the teeth, and 99% of all the body's calcium is located here. The soft tissues contain about 1% of the total body calcium, and the extracellular fluid, or ECF, contains a tiny fraction of the body's calcium, less than 0.2%. However, it's this extracellular fluid calcium, also known as the serum calcium, that's very tightly regulated because it exerts biological effects. So altogether, the storage of calcium in the body approximates 1,000 grams or 1 kilogram. And calcium in the ECF exists in several different forms. So shown on the left is the protein-bound portion of serum calcium, which is about 40 to 45% of the calcium in the ECF. On the right side of this slide is complexed calcium, meaning that calcium is joined to phosphate or bicarbonate or lactate, and this accounts for about 5 to 10% of serum calcium. And then finally, in the middle is ionized or free calcium. And it's the bioactive form of calcium, and it represents about 45 to 50% of all the calcium in the ECF. The normal values for ionized calcium are shown here, and as you might expect, this normal range is about half the total normal range for serum calcium. Since about half of the ECF calcium is bound to protein or albumin, it's not surprising that changes in albumin would affect the measurement of calcium. So low albumin is one of the most common causes of pseudohypocalcemia. This term refers to a low measured total calcium concentration that occurs because of low albumin without any true change in the body's overall calcium status. And in general, it's approximated that every 1 gram per deciliter drop of albumin would cause the measured total calcium to decrease by 0.8 milligrams per deciliter. And causes of decreased albumin include things like poor nutrition or liver disease, as well as loss of albumin through renal disease or congestive heart failure. And in all of these conditions, the ionized form of calcium doesn't change, which means that the individual shouldn't display any effects of hypocalcemia. While changes in albumin can affect measurement of total calcium, changes in pH will affect calcium binding and thereby result in abnormal measurements of ionized calcium, again, without a true change in overall body calcium. And the graph on the right might help with these explanations. So ionized calcium decreases in conditions of alkalemia because protein-bound calcium increases as the pH goes up. And conversely, ionized calcium increases under conditions of acidemia when the pH is low because protein-bound calcium decreases as the pH decreases. So the total calcium concentration in all of these conditions doesn't change. However, unlike the previous situation when we discussed low albumin, changes in pH can clinically affect individuals since these changes will be affecting the bioactive ionized calcium itself. So we just reviewed the measurement of calcium and its assessment in depth, but now let's briefly look at the remaining analytes: phosphorus, magnesium, and creatinine. And so all of these are important to assess in calcium and parathyroid disorders, but they're considered secondary analytes after measurement of the serum calcium. So starting with phosphorus, its function consists of being a structural component of bone and also being key in cellular ATP generation. We've already discussed its regulation. It's decreased by PTH via renal excretion and increased by vitamin D via absorption in the intestine. Phosphorus is high in conditions of renal failure because the kidney can't excrete phosphorus, in conditions of hypoparathyroidism or underfunctioning parathyroid, and in vitamin D toxicity. Conversely, phosphorus is low in hyperparathyroidism and conditions of vitamin D deficiency. The second analyte here, magnesium, functions as a catalyst of many cellular enzymes, including those utilizing or synthesizing ATP. The clinical importance of magnesium is that PTH release can be blunted in the presence of hypomagnesemia. Low magnesium can occur in cases of GI wasting or renal wasting. And this is important because a patient with these conditions may appear to have low functioning parathyroid when in fact PTH release is simply impaired by the presence of low magnesium. And then finally, creatinine measurement is essential when evaluating parathyroid and calcium disorders. So in chronic kidney disease, or CKD, serum calcium decreases because the failing kidneys can't adequately produce activated vitamin D. Also in CKD, serum phosphorus increases because the failing kidney cannot adequately excrete phosphorus. Since low calcium and high phosphorus are both stimuli for PTH secretion, patients with CKD, especially advanced CKD, have marked elevations in their serum PTH levels. And because the parathyroid glands in this particular situation are trying to compensate for low serum calcium and high serum phosphorus, the high PTH seen in patients with advanced CKD is usually termed secondary hyperparathyroidism. Let's now turn to the regulating hormones for calcium homeostasis. And we've already discussed PTH in detail, so we won't cover that again here. But we will talk about vitamin D and its metabolites, namely 25-hydroxy vitamin D and the activated form of vitamin D known as 1,25-dihydroxy vitamin D. And minor regulators of calcium homeostasis include PTH-related peptide or PTH-related protein, also known as PTH-RP, as well as calcitonin. And so both of these are useful to understand in specific situations. Vitamin D primarily exists in the skin as a provitamin form, or it can be obtained from supplements in individuals who have insufficient exposure to sunlight. So in either case, the precursor form of vitamin D has to be converted to an activated form through two hydroxylation steps within the body. So on the left are the steps involved in conversion of provitamin D3 in the skin to active vitamin D3. So first, sunlight converts provitamin D3 to vitamin D3 or cholecalciferol. Then a 25-hydroxylase enzyme in the liver converts cholecalciferol to 25-hydroxy vitamin D3. Finally, 1-alpha hydroxylase in the kidney catalyzes the last step of activating vitamin D3 and produces 1,25-dihydroxy vitamin D3. So recall that this step is driven or stimulated by parathyroid hormone. Then this right side just shows the equivalent of steps that occur when provitamin D2 or ergosterol in yeast is converted to vitamin D2, the activated form. So how can we use measurements of vitamin D to help us assess and evaluate disorders of calcium homeostasis in parathyroid dysfunction? Well, both 25-hydroxyvitamin D and 1,25-dihydroxyvitamin D can be directly measured. This first is considered the storage form of vitamin D and is an indicator of vitamin D status. So this number will be decreased in cases of limited exposure to the sun, decreased vitamin D intake, malabsorption where ingested vitamin D isn't absorbed into the bloodstream, and liver disease where 25-hydroxyvitamin D can't be formed. And vitamin D in this form will be increased primarily in cases of excess ingestion or vitamin D toxicity. And 1,25-dihydroxyvitamin D, on the other hand, is present in much smaller quantities in the bloodstream, and it's the biologically active form, which is really tightly controlled. So it's an indicator of how well the 1-alpha hydroxylase in the kidney is functioning. So naturally, this number would be decreased in cases of decreased kidney function, such as advanced and chronic kidney disease. And interestingly, 1,25-dihydroxyvitamin D may be increased in some cases of granulomatous disease. And in these diseases, 1-alpha hydroxylase activity may be present in sites outside the kidneys, specifically in the granulomas such as those in sarcoid and tuberculosis, for example. In cases of hyperparathyroidism, the 1-alpha hydroxylase activity increases in the kidney, and higher amounts of 1,25-dihydroxyvitamin D can be seen. Now, let's briefly discuss the minor regulators of calcium, including PTH-RP and calcitonin. So starting with PTH-RP, its effects are the same as PTH at the bone and the kidney, but it's less likely to stimulate 1,25-dihydroxyvitamin D formation. This means that it has less effect at the intestine and does not increase intestinal calcium absorption. Physiologically, PTH-RP is important for tooth eruption and normal mammary gland development, and it also plays a role in lactation, helping to mobilize the transfer of calcium to the milk. Pathologically, PTH-RP secretion is the most common cause of humoral hypercalcemia of malignancy, and it's considered a paraneoplastic phenomenon when a tumor secretes this peptide. Calcitonin is secreted by the C cells, or the parafollicular cells of the thyroid, not the parathyroid, and its effects are in fact the opposite of the effects of PTH at the bone, the kidney, and the intestine. And thus its overall effect is to decrease serum calcium. But it's much less potent than PTH, and so it really isn't a major factor in calcium homeostasis or in most calcium disorders. So then what's its relevance? Well, remember that calcitonin is an important marker for monitoring patients with medullary thyroid cancer, specifically in monitoring them for recurrence. And calcitonin is also a drug that has roles in treating osteoporosis and hypercalcemia. And this diagram reminds us of the main direct and indirect actions of the parathyroid hormone on its target organs, and emphasizes that the primary goal of this entire process is to maintain serum calcium within a very tightly regulated range on a minute-to-minute basis.